Yeah, so this talk is about eye scans only, so I'm not going to talk about MRI scans of the head and neck. We don't do it routinely, or for follow-up for metastatic disease. This is not part of this talk. So this is only about the scans, in inverted commas, that are done when you come to the clinic. Is that okay? Is that what you expect? I hope so.
Absolutely.
Okay.
Yes, thank you.
So if you have any questions, please ask, because this is the opportunity to sort of ask questions you feel you can't ask elsewhere. So routine scans that we perform in Liverpool, and I would say it's in most departments, it would be the same, is wide angle photo documentation, ultrasound, OCT, and autofluorescence. So these scans are done every time you basically visit for the first time and for every follow-up visit. And I'm going to go through them one by one, why they're done and what we can see on them. I'm not going to talk about angiography. That has really a minor part in our workup. It's sort of an old school method that's a lot more invasive. We do use them occasionally for indications of differential diagnosis where we're not quite sure, and sometimes in the follow-up if you have radiation-induced complications, but it's not a standard scan or examination anymore. So the role of the imaging, why are we doing these scans? At baseline, they aid in the diagnosis. So I would say about 80% of cases that come as new patients, we can make the diagnosis straight away. And about 20%, we really rely on the factors from the scans to help us with that. What they also do, and a big problem in daily life, are small melanocytic lesions. When you come and you don't know, is it a mole or is it a melanoma? These scans have really helped us a lot in recent years, and I come to that. And finally, if the diagnosis of a uveal melanoma has been made, the measurements from the scans translate directly into the treatment. For proton beam, for plaque treatment, we rely on the scans to give us measurements for the prescription of radiotherapy, really. When you come for follow-up examinations, it mainly helps us to assess the treatment response, most importantly, to identify a recurrence in the eye and detect treatable complications, in particular macular edema after radiotherapy. So let's kick off with wide-angle photo documentation that has revolutionized all ocular oncology over the past 10 to 15 years. When I did my training, we still had the classic slides and looked at the window really and compared and looked into the eye. It was so much more complicated and so much more dependent on the examiner compared to what we have now. It's a massive step forward to have this wide-angle photo documentation. You need to understand, this actually is a scan. It's not a photograph. It looks like a photograph, but actually it's a laser-based scanning system. So the colors do not resemble what you really see in the eye and how it is. And I come to a little bit later. There are massive advantages of this. Optos is the most common one that everybody uses, but there are other systems as well. And the massive advantage is that out of a sudden, if you compare your normal shot with your camera from a, let's kind of mild teleshot to a wide angle. And not only that, that wide angle photograph has a high resolution all through the field. So if you got the little pixel up in the upper left corner, you can zoom that up and have great resolution. What you can do with the modern software, you have a side-to-side comparison before and after treatment to look for changes. You have an excellent picture quality, even in small pupils and some patients, and that is sometimes difficult. They're very sensitive to light. It's very difficult to look into their eyes with ophthalmoscopy, whereas with this system, it's a lot less light and it's a lot easier to do. So we use it, for instance, outside oncology, a lot in children as well, much easier to examine with that. But there are some disadvantages, in particular in the lower part of the retina. Part of the retina is cut off. You cannot see on these pictures unless you're a very good photographer and the patient can cooperate. And the colors are not natural colors. That's not so much of a problem in most patients, but in the differential diagnosis in the beginning, for instance, if you have a hemangioma, that's a benign tumor that can look like a melanoma on these laser-based systems. So there's a bit of a word of caution regarding telemedicine. So if you send around pictures for somebody else to review, it's different to real photographs because the colors of the tumor are different. So this is from the Optos website, how they explain how the system works. I don't really understand. It looks quite complicated. I just look at the pictures, but you see there's a lot of technique involved and a lot of scanning. So the fundus is scanned by lasers that then make a picture, a wide angle picture out of it. It's quite a reliable system. And as I said, we use it every day. And this is your classic Optos picture that you get as a result. So just to show you how we use it in daily life, this is for a follow-up patient. This patient had a melanoma in the superior quadrant there. And you can see after treatment, the melanoma has reduced in size. Not only that, you can also see the plaque scar. So we put a ruthenium plaque on like a footprint in the snow. You can see where the plaque was, and you can see it surrounded the lesion exactly how we wanted it to. But you can see something else. This is a very rare case. If you look down there, this patient had a second little spot in the eye, and over the years it grew. Okay, and you probably would have missed that, but if with the photo documentation, you can clearly see that it grew over 3 years. This is a rare case of 2 melanomas in one eye, as documented by photo documentation. What you can also see in the lower part of the eye, some part of the retina is cut off. So it doesn't free you from doing ophthalmoscopy. We still have to, unfortunately, blind everyone with a bright light, because only with the ophthalmoscopy we can look around and see in all corners of the eye. But the beauty of the system is, this is, for instance, a difficult lesion to see on the right-hand side here. You can see that this is the baseline lesion, and the patient comes for a follow-up. So has this lesion grown, yes or no? In the old days, with looking into the eye and looking at a slide against the window, would be impossible to say. And with this system, you can then zoom up, and you can see on the left side clearly that part is a little bit larger. And you go down, and you can see the bottom part as well. There's a growth of the lesion. That's something that we couldn't detect before. And this is where this laser wide angle system really has revolutionized ocular oncology. What we also can see is the symptomatic progression. This is the fastest progression I've ever seen. A patient coming in with I thought it was a melanoma. We asked him, whenever you see any changes, come in. And that was only 11 days later. And you can see, if you look at this blood vessel there, it's cut off here, and you can see just in 11 days, you can definitely document the progression of the lesion over that short period of time. So it's very sensitive really to detect growth, and is a massive aid in our daily practice. And also to detect recurrence. Fortunately, they are rare, but unfortunately they do happen. This is a melanoma in the eye that's been treated with a plaque. So we were quite happy in the beginning. The tumor is smaller. You see a scar from the plaque. But if you look very carefully over time at the superior edge, this is advancing again, it's growing. So this is a recurrence after a plaque treatment documented by this method. It also helps in assessing the risk factors for transformation of small melanocytic lesions, and imaging plays, or scanning plays, a massive role in this. You could see this small lesion. No expert on the planet can tell you straight away this is definitely a nevus or a mole, a benign lesion, or this is a melanoma. And this is why we established, in particular, the group of Shields, 6 risk factors. So in all of these small lesions, we look at 6 different risk factors: subretinal fluid, orange pigment, a lateral extension, meaning a baseline measurement of more than 5 millimeters, a thickness of 2 millimeters, acoustic hollowness on ultrasound, and visual acuity less than 6/15, which is halfway down the chart. So the first 5 are all assessed by imaging that I'll show you today. So we don't do any magic. We just use these scans really when the patient comes through the door with that lesion, and then we can give an estimate how many risk factors are present, and that will tell us the risk of this being a melanoma or transforming a melanoma in the future. So for instance, just with a wide angle, we can measure that, and you can see here it's just below 5 millimeters and just below 4 millimeters. So the risk factor of lateral extension of more than 5 millimeters is not present in this case. So let's move on to the ultrasound examinations. They are basically a staple. These scans are a staple of every ocular oncology examination. There's a different type, A scan. Not many use it anymore. And this is a difference. If you go to an academic presentation, a lot of people still recommend the A scan, but most people that use daily life ultrasound only use the B scan. The B scan gives you like a camera image of it. The A scan is a lot more complicated. So I'm just going to talk to you about the B scan. So ultrasound is throwing a wave of sound to something that comes back, and use it, you know it from fishing and things like that. So it pings a sound wave somewhere, and you record what's coming back and compare it to something else, and that tells you what's going on really. We do exactly the same in the eye. So we ping a sound wave ultrasound into the eye and then document it and translate it into a photograph or a film. It's the standard still for measurements of tumors. And the advantages is one of the risk factors in this group, low reflectivity or acoustic hollowness, you can only pick up with the ultrasound, with no other method. You can detect pulsations within the tumor. That's a risk factor for a melanoma being present versus a hemorrhage. And you can detect extraocular extension. I'm sure you know that one of the fears of every patient is, does the melanoma grow out the back of the eye where nobody can see? I understand you can see it in the front of the eye, but what if it grows into my brain? Now, they hardly ever do it, but sometimes they have an encapsulated extension at the back of the eye, and we can only pick that up with ultrasound, with no other imaging methods. So it's another advantage. There are some disadvantages. It's very sensitive and expensive equipment. And we get a lot of referrals where the hospital basically doesn't have the right equipment. They say it's broken, it's at repair or whatever, and can you do the ultrasound for me? So unfortunately, sometimes we're like an ultrasound department for other departments, which is a big shame. So I think every eye department should have a working ultrasound, but it's not so easy to maintain. The biggest problem of ultrasound is there's a massive inter and intra-observer variability, meaning if I measure a tumor today and I measure the same patient with the same machine tomorrow, I already will have a difference in variation in the measurements. And it's even more of a difference if a different examiner uses it in a different hospital. So unfortunately, that causes a lot of confusion. We do have a lot of re-referrals where the tumor is going, regressing really, really well. But then the measurement in the referring hospital is different to the one that we had. And people feel, oh, it's a measurement of more than 1 millimeter. And this causes so much confusion. So actually, we don't find ultrasound very reliable in the follow-up of patients. And I'll come to that in a bit more detail. This is how it's done. On the left, you can sort of put the probe on the eye. We in Liverpool are a little bit different. We do all our ultrasounds ourselves. So honestly, I wouldn't never even trust my colleague to do the ultrasound. I want to see what's going on. And that's a big difference. And in other departments, radiographers do it. I'm sure they're super experienced. They can, do a fantastic job. But to me, it's such an integral part of the examination that Bertolt D'Amato always done it, and I followed his advice. I always do it myself, and I couldn't do without it, to be honest. Okay, so you put it through the lid. You can put it on the eye as well. You get a better quality, but it's a lot worse for the patient.
To the right.
And I don't find that the gain in quality, putting it straight on the eyeball, justifies that discomfort. Right. So if you push it onto through the eyelid with good gel, you usually have a very good picture. And on the right, you can see the picture that you get. It's a moving picture, and you freeze it, and you then can use the frozen pictures for measurements. So the first thing we look when you come through the door first up is for low reflectivity. And I show you what that means. You can see the tumor in the middle of the video, and you can see it's dark inside there. That's a low reflectivity, and that's an absolute telltale sign for melanoma. So if we see that, and often patients think, how can you be so sure that this is a melanoma? This is one of the signs that is, I wouldn't say foolproof, but a very, very strong sign for a melanoma compared to other tumors. Almost no other tumor does have this low reflectivity. So that's something we can only assess with the ultrasound. Another thing is a vascular activity. This is a little bit dark and difficult to see, but you can see the tumor there. And if you look very closely, you can see like a motorway of blood cells shooting through really in the middle. If you can see that now, really like an injection of ink. So this is a high vascularization, meaning this tumor has lots and lots of blood vessels in it. And this is typical for melanoma. So in that location, you sometimes cannot tell, is it a bleeding or what is it? And if you see these blood vessel pulsations, that's typical for a melanoma on the ultrasound scan. And finally, you see this is a large tumor inside the eye, but you can also see a pocket outside the eye. So this is the tumor inside the eye. And if you look carefully, you can see there is an extension of the tumor towards the back. As I said, this is a fear of almost every patient, that it grows towards the back where nobody can see. And this is one part of the examination, that during the ultrasound, we check that there is no extension towards the back. It's very rarely the case, but some cases like this, you can see it. We use the ultrasound for follow-up after treatment. You can see this tumor here in the ciliary body, relatively large. And if we have the same machine, the same patient, same examiner, after treatment, you can now see on the right side of the slide, that there is a good regression. The tumor is a lot smaller. I think you can appreciate that. So it really regressed really nicely. This is the hidden corner of the eye where we cannot see the tumor with ophthalmoscopy or wide angle photography, and we only have the ultrasound. And this is the high resolution anterior segment ultrasound to watch these lesions. So we need to perform that in every case. This is why, unfortunately, some patients do need to come to us on a regular basis, because this anterior high resolution ultrasound is not available everywhere. And if we have a tumor in front of the eye, the ciliary body, we cannot see it from the outside. The only way to really follow it is with this anterior segment ultrasound. But there are problems. And as I said, the biggest problem is the variability in the measurements. You can see this tumor, and I might measure it one day like this from edge to edge. That's what we do in Liverpool. But other people include the retina as well as the sclera, and you got the same tumor on the same day and a difference of almost 30% in the measurements. That causes a lot of confusion, unfortunately, in the follow-up. So as I said, we do receive quite a number of referrals, or the tumor has grown. In reality, it's only a variation of the measurement. So hopefully we can improve that in the future. Excuse me. The next scan is the optical coherence tomography, or OCT scan. This is one of the scans that's performed all the time. And this is, again, absolute groundbreaking new development that revolutionized medical ophthalmology over the last 15 or 20 years. All the treatments in macular degeneration and diabetic retinopathy would be unthinkable without this method. How does it work? It's like an ultrasound, but with light. So you shoot a light wave into the eye, and it's reflected in different ways, depending on how the tissue reflects the light. And it's then compared to a standard light and makes a picture out of that. And what it does, it provides a living cut, like histology. If you look under the microscope with the OCT scan, you can get almost a resolution live of the retina. It's absolutely amazing. I show you the pictures. So the advantages of OCT, it's high resolution documentation of all retinal layers. You can have a side-to-side comparison over time. It detects fluid as a risk factor, detects progression, and it also enables you to make measurements in small tumors. The disadvantage is it really goes only through the retina. And as you know, our tumors are mainly in the choroid, in the layer underneath it. So it just scratches the tumor on the surface. So it's more for retinal changes and small tumors in the choroid. But because it's an optical system, and you can think of a melanoma as being very dark, it blocks light. So if light hits the melanoma, it's reflected, but it doesn't go any deeper. There's a shadow behind it. And this is why, unfortunately, with the techniques we have so far, we can't really measure and display whole melanomas with this technique as yet. Hopefully that will come in the future. So this is a nice example. And what you do is you do a scan through the retina there. And this is resembled on your right. And you can see the resolution is amazing. So that's the vitreous. And then in the retina, you can see every single layer of photoreceptors or of the retinal layers, which is quite amazing. You can then see changes under the retina, the subretinal fluid. And in the sclera, in the choroid, you can see all these changes on the scan, which is absolutely amazing. So the risk factor subretinal fluid now officially is only detectable by OCT. In the old days, in the old classifications, it was defined as fluid detected on ophthalmoscopy, which is a lot less sensitive. So OCT is a lot more sensitive. So if you now define the risk factor of subretinal fluid, it has to be on OCT. And you can see that there, that cap of fluid over the tumor, that is one of the risk factors, pardon me, for malignant transformation. Doesn't mean it has to be a melanoma, but it's one of the 6 risk factors. And you can see it for changes over time. Again, this lesion, nobody can say, is this a melanoma or a nevus? How does it look 18 months later? Has it grown on that edge? Difficult to say. And with the OCT, the beauty is you've got the memory function. So you can take the same slice of the cake each time a patient comes. You can see there's a little bit less fluid actually on the follow-up examination. And if you measure it, it's exactly the same measurements. And that is so much more precise than ultrasound and these small lesions. So if you can see the small lesions on OCT, it's so much better for measurements. And in particular, the memory function is extremely helpful in the follow-up of these patients. No change in the measurements, although you might think it's larger. And finally, for instance, you can look also at the recurrence or the progression I showed you beforehand. This is the same patient I showed you with the second melanoma growing at the optic disc. And I put the slice at the lower end of the tumor here. And you can see the slice at the lower end during the first examination shows you choroid that is normal with no involvement. And during the follow-up, you can see how the tumor went into and grew into this area there. So we can use that OCT scan also to show you clearly that this has grown at the inferior edge of the tumor. And that's sort of a more objective way of saying the tumor has expanded. Finally, what's really a big problem in daily life now for us is the problem of radiation maculopathy, meaning that the tumor has been treated successfully by the radiotherapy, but combination probably of dead tumor material causing some poison to have an effect on the blood vessels and inflammation inside the eye, and partly because of direct damage to the blood vessels from the radiotherapy, you get leakage. Usually the retina is like a dry sheet of paper, and if you have fluid running into the retina, it doesn't work as well. So here you see a classic macular edema. So this is a macular edema after radiotherapy, and the patient will notice a decrease in vision. Now we have treatments for that, Avastin or steroid injections, and we can also see the effect of the injections on OCT. So the OCT is absolutely essential in detecting this complication after radiotherapy. It's absolutely essential in the guidance of the treatment, whether we need more treatment, yes or no, in the follow-up. Again, this is the macular edema down there, and you can see how it vanished basically after the treatment. And another case, nice treatment of a melanoma with a plaque. You see just on the edge, the plaque scar was right in the position. We didn't want to put it on the fovea to damage your vision, but you have to treat the tumor so it doesn't grow anymore. That has been achieved, but what you can see is you got a macular edema. Tumor has regressed nicely, but you got a macular edema there. So the fluid in the retina, and after treatment, you can see it's less, it's reduced. But it's like a seesaw. It usually comes and goes after treatment, and we need to follow that with the OCT scans. And what has been developed over recent years is OCT scans that go deeper into the choroid. You see a normal scan and an enhanced scan, and you can see that the lower part of the posterior part of the tumor is better visible now. So what the new developments are is trying to go deeper into the eye, into the choroid, so we can see the posterior edge of the tumor better than before. The last scan I would like to show you, this is the last one of the 4 routine scans we do, is called autofluorescence. That's a relatively new development, and it uses what we call fluorescence. Fluorescence is if you excite something with a light of a certain wavelength, and that changes and emits a light of a different wavelength. So you have that in nature a lot. For instance, here, the Scorpio, you put a particular light on it and it will shine up. And you know that from fireflies and other things in daily life, really. So you can use the same in the eye. So you again shoot a light into the eye, but you don't sort of measure the reflection. What you measure is the newly excited light from the back of the eye. And in particular, the retinal pigment epithelial cells are active. So they fluoresce. So we shine a light onto them. And if they're alive and kicking, they shine a light back to you. And that's what you can capture. It's a relatively new imaging method, and it uses fluorescence, as I said. It can, and this is essential for the detection of orange pigment. Orange pigment is one of the essential risk factors for malignant transformation, and autofluorescence helps massively in detecting it. It can also show you old fluid in the retina, which is quite important, and it can help you with the plaque margins if you're not quite sure. The disadvantage is it's subject to interpretation, and it varies between different machines. So you can't compare it from one hospital to another if they use different machines. So this is a classic example. You can see the tumor here on the left, and you can see the clear orange pigment there. But sometimes in clinical practice, you can't see it as nicely as that. But what helps you a lot is these patchy, like a cow patch, really, patches of autofluorescence there. This is typical. This is lipofuscin, is orange pigment, and they really shine up like these patches on autofluorescence. So this is one of the 6 risk factors that you can really sort of prove with the autofluorescence. And it helps you in difficult situations. For instance, this tumor is interesting because it has two parts, a pigmented and non-pigmented part. And you can see orange pigment over the pigmented part, but the orange pigment over the non-pigmented part actually is not orange, it's dark and gray. And that's often missed and mistaken. So people think orange pigment is orange pigment, it's orange. No, it can be dark over white tumors. And the autofluorescence helps you massively here. You can see that orange pigment there shines up there. But if we look at that patch, that is dark. If you go over to the autofluorescence to the corresponding spot, you can see actually shines up, it lights up. So this is definitely orange pigment over the whole tumor, and that's a massive help in the differential diagnosis. Again, another one with a dark patch over a white tumor. You learned that already, could be orange pigment, we don't know. But if we look at it in the autofluorescence, it lights up, this is orange pigment. But not only that, you can see lower to the part there, it's not much really on normal clinical examination, but if you look at the autofluorescence, like a comet's tail, if you can see that there. What that means, this is an activation of the retinal pigment epithelium, meaning this is an activated part. There has been some leakage, some fluid exudative activity over the years. So it gives you that additional information that something's been going on for quite a while there. So this is not a silent lesion, that's a lesion that has been active in the past. And finally, what we use it for, sometimes we use a low radiation energy with the plaque, not to damage the fovea. Like this tumor again, it's quite close to the fovea here. So we really have to be careful to put the plaque just on the edge of the lesion. And we're not quite sure, has the plaque worked, yes or no? And if you look at the autofluorescence picture, you can really see nicely that footprint in the snow from the plaque. You can see that curvature that goes just around the tumor, but doesn't affect the fovea. That's exactly where you want it to be. And because the retinal pigment epithelial cells have been slightly activated after the plaque radiotherapy, that lights up on autofluorescence. So that's another really good use for autofluorescence in the follow-up. Okay, and you can also use the OCT. If you can see the difference in the fovea, you can see here the normal retina where the fovea is and towards the optic disc. And you can see here the retina here is a lot thinner. What that means that really on the OCT, you can see the effect of the plaque. Obviously, it doesn't only kill the plaque, it unfortunately damages also the retina, but you can use that indirectly on the OCT to see where your radiation effect was. So what this tells us, the plaque was in the right position, and where the retina should still survive, it survived. So it's an indirect sign for us using these scans in daily life and clinic to tell us that the retina is still alive where it should be alive, and that the plaque was in the right position. And with this sort of quick ride through all the scans we do, I'd like to thank you for your attention. And of course, I'm open to any questions.